Good morning. My topic for today is on indirect pulp capping. Now moving on to the definitions. Indirect pulp capping can be defined as a procedure wherein small amounts of caries dentine is retained in the deeper areas of the cavity to avoid pulp exposure, followed by placement of a suitable medicament and a restorative material that seals off the caries dentine and encourages pulp recovery. This definition was given by Engel. The next definition by Mathewson in the year 1995 uh, defined it as the application of a suitable medicament over a thin layer of remaining caries dentine or the affected dentine after deep caries excavation of the infected dentine without exposure to the pulp. Now, these are the contents of my presentation. We'll be talking about the layers of the caries dentine, the objectives, the rationale, the indications, contraindications, the treatment procedures, and the agents used, and the outcome. Now moving on to the objectives. The objectives of indirect pulp capping is to preserve the vitality of the tooth, and the restorative material should seal the involved dentine completely, and there should be no post-treatment sensitivity, pain or swelling, and there should be no harm to the succedaneous tooth. Now the reparative dentine is the highest amount of dentine that is formed during the first month according to Trauman in 1967. The rate of reparative dentine formation is 1.4 microns per day, and newer dentine formation is faster, and primary teeth uh, show more faster formation than permanent teeth, and the rate of formation is faster in males when compared to females. Next, we shall see the differences between infected and affected dentine. Infected dentine is considered to be highly mineralized structure. It represents a superficial layer. It lacks sensation, and it is stained by 0.5% fusion dye in propylene glycol. Intertubular dentine is greatly demineralized, and it represents deteriorated collagen fibers, and it's the unmineralizable layer, whereas the affected dentine is the intermediately demineralized layer, and it is sensitive. It does not stain by any kind of dyes, and it's partially demineralized and represents sound collagen cross section and cross linkages. Now moving on to the indications. The history represents dull, tolerable pain with mild discomfort from chemical and thermal stimuli. And the patient should give no history of spontaneous pain. On clinical examination, we should find a large caries lesion without any frank pulpal exposure. And there should be a positive response to electrical pulp testing, thermal stimulation, and test cavity. And there should be the representation of normal appearance of the adjacent gingiva, and it should be normal to percussion. On the radiographic examination, we should encounter a large caries lesion in close proximity to the pulp with a normal lamina dura, normal periodontal ligament space, and without any kind of periapical radiolucency. Now moving on to the mechanism, we need to remove the caries dentine completely and cover it up with a biocompatible material. Physiological remineralization can occur only if the affected dentine contains sound collagen fibers and odontoblastic processes. Sound collagen fibers provide the base to the apatite crystals, while the odontoblastic process supply calcium phosphate from the vital pulp for remineralization. Now moving on to the treatment modalities, we're going to discuss about the two appointment technique. and of which the first appointment includes the procedure where we administer local anesthesia and isolate with rubber dam, establish the cavity outline with a high-speed handpiece. We remove the majority of the soft necrotic infected dentine with a large round burr in slow-speed handpiece without exposing the pulp. Caries peripheral dentine should be removed by sharp spoon excavators, and excavation should be stopped as soon as we encounter firm resistance of sound dentine. And the remaining dentine layers to be covered with hard setting calcium hydroxide dressing, followed by zinc oxide eugenol cement placement. And this restoration should not be disturbed for a period of about 6 to 8 weeks. Uh, in the second visit, we need to re-enter the tooth and look for the presence of dehydrated and flaky appearance of the affected caries dentine. And between the appointments, the history should be negative and temporary restoration should be intact. And the area around the potential exposure should appear whitish, which represents the pre-dentine. The cavity preparation should be irrigated and dried. Uh, the entire floor to be placed with a hard setting calcium hydroxide dressing followed by zinc oxide eugenol or glass enamel cement. The main disadvantage with the two appointment technique is that the re-entry and re-excavation may potentially increase the chances of pulpal exposure. Next, moving on to one single visit technique. Here, once again, we administer local anesthesia and the cavity is isolated with rubber dam. And cavity outline is established with a high-speed handpiece, where the majority of soft necrotic infected dentine is removed with a slow-speed handpiece without exposing the pulp. And caries peripheral dentine should be removed with sharp spoon excavators. And excavation should be stopped as soon as we encounter firm resistance of sound dentine. And the remaining affected dentine layer should be closed with a calcium hydroxide dressing. And a base should be placed with a reinforced zinc oxide eugenol or glass enamel cement, and the tooth should receive a final restoration. Now moving on to the materials used, we generally use calcium hydroxide followed by zinc oxide eugenol, dentine bonding agents. This was advocated by Foster in 2002. And then we use resin modified glass enamas, which was advocated by Farouk in 2000. And we also use light cure composites, which was advocated by Stanley in 1987, and along with light cure restoration and resin modified glass enema. The recent advances in this field include the use of emdogain and insulin-like growth factors. Now moving on to the evaluation and success of treatment. In the histological sections, we need to encounter 4 layers, namely the caries decalcified dentine, the rhythmic layers of irregular reparative dentine followed by the regular tubular dentine, and the normal pulp with the slight increase in fibrous content. The restoration should be intact and there should be no negative history of pain or radiographic evidence of any kind of abnormal root resorption and or any kind of radicular disease. Now coming to the conclusion, indirect pulp capping has been shown to have a higher success rate when compared to pulpotomy in long-term studies. It also allows for a normal exfoliation time. Therefore, indirect pulp capping is preferable to pulpotomy where the pulp is normal or has a diagnosis of reversible pulpitis. Thank you.